Please do not message or call, as the following programme is a rerun of a previous live show. Any announcements made during the repeat may now not be applicable.
Any health advice given, whether general, diet, physical or spiritual, is general only and must be verified by your doctor. If you need medical advice, please consult a doctor.
Assalamu alaikum and welcome to the Health and Fitness Show on Inspire FM. This is a live show happening today on Thursday the 16th of February 2023, and for the next hour we'll be focusing on topics related to health and fitness, so we would love to hear from you. We are broadcasting live on 105.1 FM here in Luton in the studio, but you can also listen back to the show later on the Inspire FM YouTube and Instagram page, as well as the Facebook Live page, and it'll have all the links of where else you can listen to us as well. So I'm Dr. Amna. I'm a GP living and working here in Luton, and we're here today with two very special guests that have been on the show today that are familiar to a lot of the community in Luton, Yasmin and Khuram, who were Amani's parents. So thank you for joining us, but also two of our medical colleagues, very distinguished, who have come, who were involved in Amani's care, Dr. Anup Vinayan and Professor Plaha, and I will get them to introduce themselves in a second. Now, today we're going to be talking all about brain cancers, brain tumours, and specifically glioblastoma. And that's something that's been in the media a lot, not just because of Amani, and that's something that's very close to our hearts here in Luton, but also various different celebrities across the country. And also, if you've been following the EastEnders storyline, Lola Pierce as well has also been recently diagnosed with that same illness. So there's a lot of fear around in our communities and a lot of questions that people can be having. So if you would like to get in touch, please do contact us either through the Facebook page, the Instagram page, so at Inspire FM, or at Dr. Amna GP, or you can always, as usual, text us on the usual number as well. So I would like to welcome our guests today. Thank you all so much for joining us.
Thank you. Thank you for inviting us.
I think we'll start Yasmin and Amani. Yasmin and Khuram. I know you've been on the show a couple of times before. Welcome and thank you. Assalamu alaikum.
Thank you for having us.
Thank you. And we've got Dr. Anup Vinayan, who is a consultant clinical oncologist who was involved in Amani's care.
Yes, and thank you for inviting us. And it's practically been an honor to treat and inspire such an inspiring young woman in the family who's actually trying to keep her flame alive. And thank you for inviting us.
Thank you for coming all this way. And Professor Plaha as well, who is a consultant neuro-oncologist, oncology surgeon.
Yes, thank you for the invite. Very nice to be here and try and share some of our ideas and knowledge and then answer questions from the community. So very privileged to be here. Thank you again. And again, thank you to Khuram and Yasmin as well. Thank you.
Thank you.
Thank you. So I think let's start with you guys about a little bit about your journey. I know it's coming up to a year since Amani passed away, and looking back, can you tell us a little bit about how you came to know the two doctors we have here?
Well, as soon as Amani was diagnosed, it was during the pandemic, and then quite quickly we were just given. Amani was under Dr. Anup's care, And then you basically treated Amani right through to the end as well. And then with Professor Plaha, that was just towards the end when we needed Amani's needed a shunt operation. We were told that she couldn't have a shunt operation, but we wanted to check and have a second referral. And we actually went to Professor Paneet, and he performed the surgery, which thankfully gave Amani a good couple of extra months, which we'll be forever grateful for.
Alhamdulillah.
So, thank you.
Thank you.
No, I think you summarised it well. Yeah.
So I think if I take you guys back just a little bit further, because as a GP, kind of brain cancer, a brain tumour, missing that is one of the things that kind of really scares me the most, and I think scares a lot of parents about what things they should be looking out for or what symptoms can happen. So maybe if you can start by telling us what symptoms you tend to see.
So thank you for that, because, and again, first and foremost thing we should say is that brain cancers are usually cancers that we see in people with older age. So it's more seen in people in their 60s and 70s rather than actually people in their 20s and 30s. So and the symptoms that they come up with can be varied based on the position of where the tumor is in their brain. But commonly, patients could have ongoing headaches. But patients having, if you have a headache on one day, it doesn't mean that they've got a brain tumor. And so that's not constant headaches that patients have, which no other reason has been diagnosed for, especially early morning headaches. Those kind of things is something to be looked into. People having seizures, persistent seizures, personality changes that's happening, so memory problems, but all those kind of things can be. So these are kind of generic symptoms that we have, but when we can't find another reason for it, obviously we should be thinking as GPs and as clinicians, it's our responsibility to think about other other reasons for this, for these symptoms. And I think it's very important for public to be not to be worried, saying that any time you have a headache, that does not mean that you've got a brain tumor. That's quite important to think about it that way. It's in a way onus is on us as well as clinicians to think about those differentials and and refer the patient appropriately.
Yeah. What can you expect if you are coming to see a doctor about, and your concern is the fact that you might have a brain tumor or your child may have a brain tumor? Because I think sometimes the expectation with a lot of patients that I see are, I've had this headache, like you say, for a day or so, and therefore I want a scan. Would that be usual practice?
I think the one thing we must remove is the fear that a headache means a brain tumor.
Yeah.
If I put things in perspective, we are a population of almost 70 million. We diagnose about 5,000 brain cancers every year, so a relatively small proportion. If you look at headaches as a symptom, the number of people who would have brain tumor is very small. So every headache is not a brain tumor for sure.
Yeah.
I think where GPs would be vigilant is somebody comes back with recurrent symptoms with more than one visit, or have other neurological symptoms. What I mean by that is weakness or speech problems or memory. Then I think to make a referral on to a clinician at tertiary center would be appropriate. And I think most now would do a scan, because MRI and scans are not, you're not exposed to radiation. So that's the route I would take, but not every headache is a brain tumor.
Yeah.
The message there,
and I think
to take
that's
the fear out.
Yeah, I think that's a really important message, especially at the moment when there is kind of all of this awareness. And obviously we've talked previously about why it's good to have that awareness into the research that's needed, and we'll talk a bit later on about kind of treatments and what the future looks like, but that actually not every headache is a brain tumour.
Yeah.
And do you see that, I don't know if you have any kind of figures, even if they're not kind of official figures, of how many people you see that then do not have brain tumours?
I think we probably are the wrong ones to answer, because we are sitting at a tertiary center. So every referral which comes to us at a tertiary level has a diagnosis. We are probably, I'd say to Dr. Anup as well, not the ones to make that. If somebody doesn't have a brain tumor, they won't come and see us, because we are so subspecialized.
Yeah.
And I think actually that's a good point to make, that actually you see so few of those people that have
Absolutely.
the symptoms that you said, the headaches, because they need to have specific features, they need to have all of those other things, and they would have gone through lots of different levels before they get to that kind of specialist stage, and at that point then it's kind of a confirmed diagnosis.
Correct. So we are sitting on the top of this pyramid with brain tumor. So there are a number of people at the base of the pyramid don't have a brain tumor.
Yeah.
So I think that's the message.
Yeah.
It's a very, very rare condition.
Yeah.
And it's a very rare cancer.
I think I 100% agree with Prof there, because when we are sitting in our clinic, even though it may feel like there is actually a lot of patients coming with brain tumors coming to the clinics, but the reality is that it's a rare tumor.
Yeah.
Compared to other cancers which is out there with breast cancer, lung cancer, bowel cancer, brain tumors are still very rare to happen. But as Prof was saying, the onus is actually on the clinician to think about those options when a patient comes with these symptoms and do the appropriate referral.
And also, I think if you have that fear, to discuss it with your doctor, because actually with your GP when you go to see them, so that they can be able to reassure you that actually these symptoms don't sound like a brain tumour for these reasons. Like you said, it's usually an early morning headache that persists, that keeps coming, that's maybe getting worse, that has other different kind of really serious symptoms with it, and not just towards the end of the day when I haven't had much to drink and I'm really tired and I've not had much sleep, that I get a headache kind of behind my eyes. And I think that's really important. But also I feel like my job as the GP is to recognise and ask that question, what are you worried about? And if you are worried that you might have a brain tumour, or your child has a brain tumour, say that. Don't be afraid to say, I am worried about this and this is what I want, and then it can be that dialogue.
Yeah.
Another symptom as well is problems with your vision. So sometimes as well you can go to your opticians and get that checked as well. So that's another port of call.
Yeah, because it's quite difficult to get hold of GPs at the moment. Not having a dig at you, but what I would suggest
say we're
is,
probably not the best people to sort out eye things, and actually if you can
so I think definitely see an optician. They'll be able to check if there's pressure behind the eye.
Exactly.
In fact, I remember now with Amani's situation, 6 months before she had a seizure, she did say to us, I think I've got an eye infection in one of her eyes. And she went to the GP because she was a bit older. She went herself. And she didn't have her own regular GP because she just moved back from university, so she went to the out clinics.
Okay.
And I remember she saying to us at the time, they said, they called another GP in to look at my eye. They thought it was a bit strange, it was only in one eye, the infection. And they said, if it doesn't clear up after a few days, here's some drops, go to the hospital. So we kept looking at it, is it getting better, it's getting better. And then at the same time, but another family friend, he'd got a slight eye infection, and we thought, you must have given it to each other.
Yeah.
And then after 2 weeks, strangely enough, her eye cleared up. So we thought, it must have been an infection. But if what the GPs, because they don't have the equipment to do those skills, what they probably should have said to her maybe is, why don't you go to an optician where they can look? You'll get an eye appointment very quickly. They'll take a look. If you don't want to go to A&E, and the optician would have picked up her pressure and probably sent her straight to A&E.
And actually that's a really good point to make. So I do always kind of tell patients that, I only have a little tiny handheld light in my room, and, of course I will try, but the optician has, a whole setup, a massive machine, and actually there's a service called QS, which I can't for the life of me remember what it stands for, but it's something related to, I think it's Community Urgent Eye Service, that sounds about right, that is available across Luton, that anyone can self-refer to. So if you just Google QS, CUES, eye service, you can get the number, or you can call your GP surgery. The receptionist can give you the number. I think the pharmacists have access to it as well. It's a free, it's an 033 number, and they will speak to you, they will find out what your symptoms are, and they will get you booked in with an optician. If you have any kind of loss of vision, change of vision, a red eye, any kind of floaters that you can see, they can arrange that for you. And obviously if there's something that you're saying to them that is much, sounds like it's much more serious, then they can either direct you to the GP or even to the A&E clinic. So that, I think that's a really good point about kind of things to watch out for and what we can be doing for ourselves and also for our families if symptoms happen. Okay, so we've talked a little bit about kind of symptoms, and obviously this is a horrible diagnosis to receive if you've kind of been through all of that process and you have been told that you do have a brain tumour. What are your options then when they get to you at the top of the pyramid?
So I think once we've actually seen an MRI scan which suggests a diagnosis, like a horrible diagnosis, like a glioblastoma, or even saying what we call as, when you look at glioblastomas as such, that's a spectrum of disease in the sense that, when gliomas are primary tumors of the brain, so it starts from the supporting cells of the brain. And it can be graded from grade 1 to 4. And grade 3 and 4 are the ones that we are more concentrating on because they are considered as the malignant or cancerous area. And grade 4 being the most aggressive. With a suspicion from the images, first and foremost thing that we would want to do, and which has got the maximal impact on the outcome, is having a surgery. So a surgical resection, or what we call as maximal safe resection. I'll actually let Prof actually explain that much more because
that sounds way too technical for me. So, cutting bits out, basically. Okay.
So operation is the first and foremost treatment that we would think for, as long as it doesn't actually cause harm to the patient.
Yes.
And I think that's where the first thing we would want to look at. If in situations there can't be an operation, then we would have to fall back on other options like chemotherapy and radiotherapy there. And even if after the surgery, we would want to think about those treatments as such. So these are, when you look at an operation followed by chemotherapy and radiotherapy, is considered as the standard treatment or gold standard treatment that's available with the scientific knowledge at present. Now I'll probably leave it to Prof to talk about this operation side of things, which I've got no expertise on.
So I think the one thing which makes the biggest difference for glioblastoma or brain cancer, as we call it, is surgery. The focus has shifted in the last sort of 10 years, if not more, that the more you take out, the better. And more you take out, the better safely without causing harm. That's the important thing.
Yeah.
If you harm somebody, give them a stroke or paralysis or affect them with their vision, then you have had a detrimental effect on their quality of life.
Yeah.
If you can't cure someone, sadly this is not curable at the moment, then the essence is in maintaining their quality of life for as long as one can. So surgery has improved a lot in the last decade, I would say. There are new tools we have. There are new drugs which have come, NICE, which is the National Institute of Clinical Excellence, approved a drug called 5-ALA or Gliolan, where it helps the tumor glow in the dark when you do the operation. So you can differentiate the tumor from the surrounding brain. So you take the tumor out, don't harm the surrounding brain. So that became standard of care for everyone across the country in 2019.
Okay, wow.
NHS England through NIHR, which is the National Institute of Health Research, have funded close to 2 million a multi-center trial which Oxford is running, which is to raise the bars of surgery beyond the 5-ALA fluorescence I'm talking about. You use other gadgets like ultrasound. You look at more advanced brain imaging, which in addition to looking at the tumor, shows you the nerves which are controlling your speech function, your movement, your vision, so you can see them during surgery. That trial is outgoing. It'll continue for another few years, and I think the results are positive. It'll push the standard of care to a new level across the country.
Amazing.
So it doesn't matter where you have your brain tumor, where you go, everybody gets the same level of care. That's the goal.
Okay.
So I think on the surgical front, there are advances happening to make surgery safer for patients. And then once you get somebody through an operation where you've taken a lot of it out, they're in the best place to go on and have radiochemotherapy afterwards.
Yeah.
That's the first initial step with managing this.
And I think it's important to kind of understand that journey, that it's not the same as kind of having a lump on your hand that you can just kind of very clearly see, cut out, and then you're better the next day. It's actually a whole process that, unfortunately, probably by the time it's been found and, you've had symptoms and we've managed to diagnose it and you've gone through all of that process, that actually you will be in that process for a long time regardless of the outcome.
Yeah.
And was that something that you guys were expecting when Amani was diagnosed?
I mean, Amani was diagnosed during lockdown, so we actually got her prognosis. I remember Anup Vinayan, I didn't even really know who he was or what he looked like at that time on the phone.
Yeah.
And obviously it was a big shock to us because when Amani went into hospital the night before, the consultants weren't there. Although they called Yasmin in to tell her that they'd found a tumour, it didn't really mean much to us other than, and your first perception is like, oh, it's just a lump, you just pick it out. So we went to bed, although we were worried, we never heard of cancer of the brain. So in our mind, I went to sleep thinking, I'm going to get a phone call tomorrow and the doctors are going to say, she's got a tumour, we're going to cut it out. Luckily we got it, you'll be fine. So to get that phone call, I still remember it.
Of course.
It's a complete shock, and to be honest, it doesn't really sink in for a long time, it still really hasn't. To be honest, you go to bed thinking you're going to wake up and everything is going to be normal, and it's not. So we were completely in the dark about cancer and brain. We'd only heard about cancers, breast cancer, bowel cancer. We'd never heard about anything like that, so it was really utterly shocking for us.
And then to have the prognosis that we were, sadly you had to deliver to us was, for your 22-year-old daughter was just, not what we were expecting.
No,
sure,
of course. And I think we'll talk a little bit later about kind of the importance of kind of continuing to raise awareness, because like you say, people hear of breast cancer or prostate cancer or cervical cancer because there are screening programs, and there's a lot kind of talked about, or lung cancer related to smoking, that kind of thing, but not so much about brain cancer, or maybe not so much previously, maybe over the last couple of years a lot more. And I think, do you think that's more kind of also a reassurance that actually it is very rare? It's not something that will affect every family or every community.
I think you're right there. If you look at all the cancers in the body, and if I were to rank them, this will be not even among the top 10. So it's so rare. In some way, that's good news. But also, if you look at historically, the funding has always been for other cancers: breast cancer, skin cancer, lung cancer. And NHS England have now taken a view of increasing funding for brain cancer over the last few years. And a lot of it is driven by some of the media personalities who've got it. A lot of the work both of you have also done in trying to raise awareness, and that helps. Because we need to reach a point where instead of saying it's incurable, we are saying it can now be cured. I think we are far from it at the moment.
Unfortunately. But it's very reassuring what you're saying about the increase in funding, but also the advances that are coming with regards to the treatment and the possible treatments, and kind of mitigating the risks related to that, to the treatment.
That's right, because even though we still quote clinical trials and outcome which has been done in 2008, which is considered as still the standard of treatment, as Prof was saying, there's been improvement in terms of surgical techniques. There's been a significant improvement in terms of radiotherapy techniques that's being delivered, and it's kind of around the country we use much more modern radiotherapy techniques which can reduce the impact on the rest of the brain and thereby keeping the quality of life of the patient as much as we can. But sadly, we still are in nowhere near saying that this is a curable situation. And we would need more funding, more research to try and actually move a step closer to that.
And sorry, I think there's a danger as well, because always like saying it's rare, because it's rare until it's your family. And
then it doesn't really matter because it's affecting.
There's a whole family, there's a whole friendship network surrounding them, and it doesn't feel like it's rare when it's you.
Of course.
And when you look at it, the number of life years lost is much higher when coming at brain tumours because of how it affects that person and the family.
And it's a very aggressive tumour, isn't it?
It is. It's unfortunately a very aggressive cancer compared to some of the other cancers where we can actually quote life expectancy or survival in years. As we know, the survival is quite limited with these kind of aggressive brain tumours or brain cancers.
Not on your hands either, is it? So,
Yeah, and you said, that was the next day that you were kind of told about the prognosis, which must have been really, really difficult.
Yeah, I mean, I think you end up doing a lot of research because you're told there's no cure. We hadn't had a decision about surgery then, so there were still options that we were looking at. So we were looking, my brother-in-law and our family were looking at other options abroad, and I do remember spending a lot of Anup's time showing him or talking to him about different options. I was thankful that we had a very good experience without the doctors here, and I know that there's a lot of pressure on their times, but I think Anup tried to, in the nicest way possible, say, look, pursue any options you want. Be careful about spending a lot of your money.
Well, when we come back after the break, we'll discuss those options in a few minutes.
Sure.
The following program is a rerun of a previous live show. Hence, any announcements made during the repeat may now not be applicable.
Any health advice given, whether general, diet, physical or spiritual, is general only and must be verified by your doctor. If you need medical advice, please consult a doctor.
Assalamu alaikum and welcome back to the Health and Fitness Show. I'm Dr. Amna, and today we're joined by Dr. Anup Vinayan and Professor Plaha. Sorry, I'm having real trouble with your name and title today, as well as Amani's parents, Yasmin and Khuram, and we've been talking about all things related to brain cancers and all the things you need to know. Now, we have had some questions already come through, and we've talked a little bit about addressing some of those and addressing the fears that people can have about if they're concerned that they may have a brain tumour or somebody else in their family, as well as some of the treatment options available. But if you do have any questions, please do text them across to 0777 948 1822. Right, so just before the break we were talking about the different treatment options, and unfortunately when you hear of a diagnosis as severe as this and as horrible as this, I think it's natural to kind of be Googling and asking everyone and talking to as many people as possible about what can possibly be done. And Khuram, you were talking to us a little bit about that journey for you.
Yeah, I think because Amani was so young and before she was diagnosed, she appeared to be completely healthy. I think Yasmin and I and our family decided we're going to do everything we can, and we spoke to Dr. Anup, and obviously he's duty bound to give us the honest answer whether we like it or not. And to be honest, the reality transpired is it was within generally those paradigms, although Amani managed to survive a little bit longer. You just looking across to America or to Europe where there's a bit more funding or private funding, other options, and you're always reading about the stories that a couple of % who survived, and you're hoping your child or spouse or parent even will be part of that percentage. Of course, what we realise, brain cancer is quite individualistic, and it's not just about the grading, but there's even a spectrum in between that. And also it depends where the tumour is and whether you can have surgery or not. And so we did look abroad, and I did run everything past Anup. In fact, it was Dr. Anup who suggested trial drug called ONC201, and eventually I went abroad and to Germany to source the drug. And we believe that as well as the surgery that the professor did, we believe coupled with the medication, we got a bit more time with Amani, because her tumour was very big.
Yeah.
It was, I think, over 5 centimetres by 4 centimetres when she was diagnosed.
Yeah.
Huge. And after the radiotherapy, which didn't work, it was even bigger. So, and then you've got all the fluid build-up. So, it did shrink. I mean, I think there was a period where it did shrink for a little while, and maybe Anup can explain why some tumours do that and then grow back aggressively.
I think, as Khuram was saying, these tumours are not, unfortunately curable, but some people do get a response where you get some shrinkage of these, with the treatment. And majority of the time, what can happen in those settings is that you give the treatment that's available to us, which is considered as gold standard treatment at this point of time, and you have part of these tumors which are responsive to these drugs and radiotherapy, which gets killed, and the tumor shrinks. But there is actually another part of that tumor which is not responsive, and eventually that starts to grow. And that is in fact the reason why the disease, cancer grows back in majority of the tumors, not just actually brain tumors. And again, it's important to kind of mention that Amani's circumstances was a subtype of the brain tumor, which is actually getting more and more recognized now, where you have a specific change in the gene of the tumor, called histone mutation, and that's where we knew that there was a clinical trial that was done in the US, where we were where the drug called ONC201 was found to be useful in some early clinical trials. So that's where we were trying to source that. We wrote to the company to try and see if we can actually get that as a compassionate basis. Unfortunately, that was not possible, given because of the fact that there was no large trials that were done.
Yeah.
And in fact, there is actually a new clinical trial that's being starting for that specific type of the glioblastoma, which is going to be open in UK as well soon. Hopefully by the middle of the year or end of the year, we'll be actually opening with the company trying to do that larger clinical trial. So, and at the same time, when you look at the glioblastomas per se, over the last 15 years, there's only been a handful of trials which has actually shown to have some improvement in their outcome. At the same time, so that's where it's really important for us as clinicians, as researchers, as a whole community, we would be looking at trying to improve the research for the brain tumor. And lots of groups are trying at the moment, but we need to carry on doing that more and more.
And it is that raising awareness through different charities, kind of continuing to have these conversations and making sure that, and I know that was part of Amani's legacy, and she was doing a lot of that, when she was alive, and you guys have continued that amazing work after her death as well, and just making sure that everyone is kind of talking about it. Any thoughts?
I think as Anup has said and you mentioned, the focus is really on trying to find new things to come through. And we are getting more funding, probably not enough, but I think more the better. We have a new trial starting in Oxford. It's called Combat GB. GB is glioblastoma. And it's looking at delivering immunotherapy in a new way for this particular tumor. So it's a novel approach, and I'm hoping it'll be open by the end of the year. So one more to the basket of new things to try and find a solution here.
And I think for me as a doctor listening to this all sounds very reassuring and very kind of, there's a lot of focus on all of the right things by the specialists at the right time. There is an awareness that actually this is needed. There's an awareness of exactly what is needed to be able to improve that care. But I also hear it from the side of the parents, or somebody who is affected by this type of cancer, that actually maybe that's not enough, and we kind of need that right now. And how does that feel? I
mean, it's too late for us, really, isn't it? So the motivation for for Yasmin and I, and even Amani's motivation, because at the end of the day, it's very difficult to have conversations with your children about them dying.
Yeah.
It's almost impossible. But Amani knew, and we knew. And so when Amani was doing her fundraising, and as you know, she raised well over 100,000 so far for brain tumour research, for the research centres in Queen Mary, and specifically for glioblastoma. She wasn't doing it for herself, she was doing it for other families. And really Yasmin and I's motivation is really to keep Amani's name alive, her legacy alive, and we don't want other families to go through what we've been through. It's impossible to describe how difficult it is to see, and the brain is probably the most critical organ of the body, not the heart. Seeing each faculty slowly being stripped away from your children, their ability to see properly, their ability to walk, their ability to think. I'll let the professor talk about the doctors talk about the effects of the only drug that really works in stopping swelling, the brain, dexamethasone. Or every faculty being stripped slowly, it is heartbreaking. And
of course,
really, that's where I suppose the doctors can say about what they can offer in the terms of support for families going through us, because it's bad news usually.
I think you've picked up on kind of three really good points that I kind of want to explore in a bit more detail. Firstly, the side effect of treatments, because I think sometimes people, like we said, they know they have something, they want it cut out, they want it treated, and that's it. But actually those treatments can come with a lot of risks and a lot of side effects that may or may not be tolerable. And then you also mentioned about support that is available, and maybe what we can do if treatments aren't possible, and what else as a clinical team we can offer patients. But also I really want to come back to that conversation, that really horrible conversation to have with a loved one about the amount of time that they have left, which I think can sometimes be the scariest thing of all. How do I tell my mum that she's dying? Someone's just told me, how do I tell them? But let's start off with the treatment side.
As I said earlier on, the current treatments that we offer is by using radiotherapy for these brain tumours, and we use chemotherapy as a supportive drug in the beginning along with the radiotherapy, and then we continue that on, and that treatment regime has actually shown to have the maximal impact in terms of delaying the growth of the disease further. But as we all know, when we are actually treating, it has got an impact as well. And that's what we've got to always think about as clinicians. What is the impact that I'm creating to that individual patient? And what is when we can't cure, we've got to also balance that with the quality of life that we can actually leave that patient with, and what's that extra benefit. So it's that benefit versus that side effect that we create for these patients. And it is difficult to have those conversations even as a clinician to an individual patient, where we're actually saying that on balance, look, it may not be the right thing for you to have treatment, and we need to think about concentrating on the side effects and keeping your quality of life with whatever medication that we've actually got. And even when you look at that, those medications are limited in terms of what we can actually provide. And as Khuram was actually talking about, some of the things that what's really important for us is to make sure that the family and the patients do have the support in the community, which is a lot of the times we obtain that through the local team, the local hospices, the community palliative care team, who can actually support us looking at their mobility. Can we support them with their mobility in terms of their speech? Can we actually support them in terms of managing the speech as long as possible to the best of their ability? If there is swelling in the brain, can we use some medications to try and reduce that swelling to keep that quality of life? But again, as Khuram rightly pointed out there, some of these medications like steroids that we use have got side effects. So when you're using it for a longer period, that creates a lot of side effects, which itself can take over. So it's looking at, can we use it to the lowest dose possible so that we can keep the person well, is the kind of key there. And I can't actually negate, because the nurse specialists that we have, who are the key workers for the patients, play an absolutely important role in having that communication going, having that support, being available to that patient all the time. I think, and we need to look at, again, the funding needs to come to improve that community support in the community for these patients.
That whole management, not just about
giving that radiotherapy or chemotherapy.
Yeah.
It's about that whole support that is needed for this patient. And I think that's where, obviously we need to look at investing and improving that, outcome. That will improve the outcome, I would say, or the journey that the patients go through. That will improve that.
And not just the patient, but everyone around them, like you said, the whole community, and how they can be supported.
I think it's hard. You mentioned first, you said, to give your child and discuss dying is not nature has created. You expect your children to die after you, not the other way around. So I don't think I can imagine the pain you've been through. I think from a clinician's perspective, I would say when we see these patients in the clinic, what we can give them is time. To rush them through is the wrong thing to do. We are under pressure on the NHS, you book clinics, but for example, now we have an hour slot for somebody with a new diagnosis, because you need that time to give. And then communication. You have lots of questions, it's something out of the blue, and we need to take the time to give that to you. And as Anup had mentioned, community support makes a big difference. But what I've also seen is where patients come with a lot of family supporting them, they do immensely better than those who sadly don't have any family support. You can provide all the external artificial support, but family support makes a big difference. And I could see that when looking after Amani. Mom and dad were there, sleeping on the floor in the hospital bed 24/7. I came in the night, morning, one of them were always there. You see, that says it all. So she has, I don't think you could have done anything better in terms of the support you gave her, because you were there around her, absolutely, the cushion and guardian. So hats off in every sense of the way. Yeah.
And I think it's important for the patients to bond with their doctors as well. We, like I said, we are very fortunate that the two doctors we have here, spent a lot of time and gave Amani time, whenever she needed the question. Sometimes she found it a bit overwhelming and we'd have to intervene. But we never felt that we were rushed. I remember, obviously, Anup we spent a lot of time with, and he would spend hours on the phone with Amani and ourselves. Most of the questions were probably quite ridiculous, but he'd probably heard them 1,000 times before, but very patiently treated us as the first time he's asking us. And I still remember with the professor as well, when our interaction with the professor was slightly less because it was surgery based and it was out of our I remember before surgery he patiently talked us through and said, I've got surgery in the morning, afternoon and evening. I was thinking, when do you guys rest? And I remember he said, we're going to do surgery on Amani the next day. And I remember our experience in London was slightly different, that we weren't getting any communication. And I remember the professor said he's got to do surgery on Amani, probably second or third on one of his list of how many brain surgeries he's supposed to do a day. And I remember he came off after surgery, and Yasmin and I had 101 questions for him. Apart from, has it gone okay? Did it work? Did this? What now? And he spent, I think the professor spent close to an hour with us, just after Amani's shunt surgery, talking us through, reassuring us, and we just felt safe, didn't we, for that little period of time. And I think it's the best the doctors can do, especially when you've got bad news, is to give that time, even though they're really pressed for time.
And I think you rang as soon as she'd finished her surgery as well, because obviously we were anxiously waiting for any news. So rather than just making us wait until she was wheeled back into the ward, you sort of ran
I think that was, and I know other experiences have been very different, and even our experience in London was very different, not naming names, but we didn't get any information. We had to go through all this network and stuff, what's going on with our daughter, and that, as a parent, you feel completely at a loss anyway,
Yeah.
and to not be able to communicate with the people treating your daughter or your son or whoever, it can be, you're already depressed as it is.
Yeah.
It can really drive you right down. And like I said, fortunately we were lucky to have these two doctors on our side.
And it sounds like you have gone above and beyond, not just with Amani, but in general, as clinicians, as doctors, and kind of providing that care, which is obviously the thing that you remember, and
even now,
in
I
minute
remember.
details, an hour, a year later, that kind of feeling supported. So thank you for that. But like you said, sometimes people don't have that same experience, and that's unfortunate. And that might be for a number of reasons, where not just kind of communication failures. People sometimes don't get on as a kind of people, maybe, or it's a very difficult scenario, and some people might think, actually, I want a different opinion, or I want to speak to somebody else. And sometimes there can be a little bit of fear from patients. So I'm always kind of quite happy for, well, not that sounds wrong. If somebody has seen me and I've tried my best to reassure them that, they don't need antibiotics, for example, for their cough, but they're still not happy, and I've tried my best, and, but I can still feel that actually they're still uneasy, they're still not happy with the outcome. I always offer, well, you can see one of the other doctors today, we can get that sorted for you, so that you leave feeling a bit more reassured. And obviously that wasn't needed in this scenario, but
that's extremely important, because majority of the times it's a pressure in the NHS that we have, as I think Prof's actually privileged to have an hour to see the new patients, and a lot of the times in other centres is half an hour or 45 minutes max that you get to see a new patient, which is not enough. It's the pressure from the in the NHS is probably what creates that lack of communication, or kind of minimises that time. And as a GP, you would know with 10 minutes consultation that's actually being given, isn't it? But what I feel always is that when you're delivering a diagnosis like this, you want to put yourself, what I would want if I'm actually sitting in that chair.
Course.
And that's one of the things that I work with. But at the same time, as you rightly said, it is a right of the patient to have a second opinion, and we always encourage that, because and as I said to you before, it's absolutely important for the patient and the family to be comfortable with whatever treatment your clinician is actually given, and going for a second opinion. A lot of the time patients are quite embarrassed to ask that, which is actually not right. We should be actually promoting that, because as a clinician it gives me confidence when you go for another second opinion and comes back with
exactly what you said. You're like, okay, that's fine, I haven't missed this whole thing.
So we're all human, and it's always important to have that. It's good to have that second
in fact, Professor Puneet was our second opinion, because we were unhappy with London, and we expressed that to Anup, who were in touch with. He said, well, why don't you get a second opinion? And Dr. Anup was always like that throughout his. He knew, with our daughter being so young and the prognosis, we were going to ask loads of other doctors,
of course.
And we would even suggest, look, why don't you go here, there, everywhere. Very confident in his own decision, but he knew that as parents and other families as well, we needed to hear that from different experts, and nobody was offended. So
and I think we're in a world where you have access to a lot of information on the net and otherwise, and families need to be absolutely satisfied they've done everything for their loved one. You don't want that guilt later on, and whether that everything is a second opinion or seeing somebody else or doing something else, I would say encourage them. You need to be satisfied you've explored everything, and then despite this, sadly this is what it was.
But at the same time, it's quite important, as I've mentioned previously as well, to look at saying that if you look around, you might see some early trials which has actually been done on not done on big clinical trials as such, or there might be people who would actually promise the world to you. But I think just be making sure that whatever you're reading in the internet is not always true and not always applicable to you.
Yeah. And that's difficult. I mean, I can't imagine what you guys have gone through from a kind of a personal level, from a family level, and, you know, seeing your daughter go through that, but also even from a clinician point of view, you know, I can't even imagine the impact that this has on you guys as doctors every single day, you know, needing to have these really difficult conversations, sometimes knowing that actually, you know, we can do all of these treatments, but actually the outcome will not be good, and it may be, you know, in only a couple of weeks' time.
Yeah, I think it's important to... Sadly, it's an incurable disease. You have two outlooks to it. One is it's incurable, I'll do whatever I can, and at the end it's not good. Or you have that passion to say, let me do my best to do what I can, and then nature takes its course. In what way? So I think if you have that sort of attitude, the disappointment as a clinician is less, because you've given your best. I can sleep well at night, I've given my best. If I do it as another day in my office and come and go, then I'm not doing my job properly. So and sometimes it's difficult, you know, you despite what the medical fraternity says, sometimes you get attached to families.
Of course.
You know, there's a living example here. I now know them beyond where I treated them. But I suppose at the end of the day, we are still humans. So that human touch does play in, and then you just accept it. And I have, over the years, sadly, and for the good, I would say, number of patients and their families I've bonded very well, and now at a personal level. But that's part of life, I would say, and in some way, if you take a personal interest in it, you then do your best for them as well.
Thank you. That's very nice.
I mean, we don't carry any guilt as a family on the medical side, because we felt we tried everything, and we felt supported by our doctors, and every avenue was explored. So we don't carry that trauma on top of the other trauma. Our trauma is just learning to cope with losing our daughter, and learning to adjust to our new family dynamics, and not seeing her there every morning and missing her. But from the clinical side, we were really happy, you know, and grateful.
And I think, you know, the show's about to end because I've looked at the timing wrong again. But if everyone listening could please just read Surah Al-Fatiha for Amani and for everyone else who has lost their lives to this horrible disease. And I just want to say thank you to everyone for joining us today, and thank you specifically to Dr. Vinayan and Professor Plaha for being here. And we will post all the links of all the ways that you can support this research. Assalamu alaikum.
Thank you very much.
Thank you.
Thank you.